Okay. All right, so we're going to kick off everybody. Everybody back in the seats if you can. That'd be great. Hi, Owen. Thanks, Emil. Okay, wonderful. So, hi everyone. My name is Claire O'Connell, and it's an absolute pleasure to moderate this super panel this morning. We've got a great breadth and wealth of expertise here on stage. It really has been an amazing 24 hours. All credit to everybody involved. It's been so enriching to catch up with many of you again and to meet lots of others for the first time as well. It's given me lots to think about, everything from fruit smoothies to pipework. It's like all good. And I suppose I was saying to Karen earlier, as a freelance, I'm a science communicator, but I work with lots of different organisations and institutions. And you know, I've experienced the clang of those pipes and, you know, or the shutdown of the pipes when somebody who came up with a workaround suddenly leaves. And, you know, it's a really, I think what we heard this morning, it's so important to appreciate how important those kind of things are for trust and collaboration. So the topic of today's panel is working together for innovation and impact. Are we there yet? So, you know, that does remind you of the kids in the back of the car roaring, like, are we there yet? Are we there yet? And I suppose if we were just to answer that question, it would be a pretty short panel discussion. But it does give us the kind of the framework to think about this as a journey. And, you know, where are we going? How fast are we getting there? Are there things that are working? Are there things that are impeding us along the way? How can we get to where we need to go as collaborative teams? And so thank you so much for your questions this morning. I had a frantic 5 minutes there with the facilitators kind of going through the themes that came up, and we will be touching on those. But first I want to introduce these wonderful people on stage. So I'm going to go in the order that they are on my list here. We have Professor Owen Smith, who's Professor of Child, Adolescent and Young Adult Oncology at Trinity College Dublin. And Owen is a consultant paediatric haematologist at Children's Health Ireland at Crumlin. So very welcome, Owen. We've Chris Ryan, Head of Research Services and Policy in the Irish Government Economic and Evaluation Service in the Department of Health. Dr. Janice Bailie, Assistant Director, HSC Research and Development Division, Northern Ireland. Dr. Deirdre Lillis, Assistant Secretary General at the Department of Further and Higher Education, Research, Innovation and Science, and Dr. Maria Quinlan, General Manager, Research and Development and Health Service Executive, and Dr. Mairead O'Driscoll as well, CEO of the HRB. So, as I said, you're very welcome. This is like it reminds me, you remember the supergroups in the 70s where you had all these like star-studded people. So this is like one of those panels.
I remember the 70s.
So do I.
Yeah,
so do I. So as I say, you've been working as a room on questions, and you know, I think this is the most fluid panel discussion I've ever been involved in, because normally I think about the questions a lot beforehand, but we really wanted this to be much more interactive with you guys. So I suppose in no particular order, you know, one of the big topics that came up for discussion was the public-private partnerships and how important it is that these happen, that there's lots of energy involved in sort of, you know, wanting this to happen, but what is the mechanism to unlock it, and who's responsible for, you know, knocking those heads together, making it happen, and you know, what's the vision as well in public-private partnerships? You know, what can research offer to collaborative partners? Is there anyone on the panel who'd like to sort of weigh in on that? You know, how do we make public-private partnerships happen? Let's take it as a given that we need them, first of all. How do we make them happen? Deirdre, you're nodding your head?
Not quite. And this, I put the government hat on, and this, you know, the challenges are there definitely. I would say the concern on the public side, it's public taxpayer money, has to be spent well. And there's also things like state aid rules where you can't, you know, use public money to generate profit for companies. So it's challenging, definitely. It's not insurmountable. There are models there. Two we're working on at the moment. You know, the philanthropy model is always there, where a company makes a donation and gets no return, no obvious direct return is the philanthropy model. On the SFI, for example, or have a strategic partnership model where there is more of a return to a particular company. That's trickier, definitely. I'd say, again, the will is there, the intent is there, but the mechanics of how to do it is really challenging. And I would say it's absolutely a direction we have to go. A lot of the European missions and partnerships depend on being able to bring private, public together around challenges, but tricky, but not insurmountable, I think, is the...
Good stuff. Janice, any insights on that?
Well, yeah, I mean, from our point of view, a lot of the work that we would do with companies, we partner with our regional development agency, InvestNI, so they have the ability to fund into a company, but it often tends to be, some quite small funding that they put in that really oils the wheels of that collaboration, and the company then comes in with some in-kind contribution, and everybody gets something out of it, but the company doesn't make any big money. So we would do a little bit of work with Invest and our partners in the Department of Economy to really try and build those relationships and make it easier for companies to work within health.
That is enough of a value to the companies to get them to the table, is it?
Yeah.
Okay, yeah. Owen, did you want to come in?
Yeah, so I think we need to start thinking outside the box here. Instead of sort of thinking about why we can't do it, we need to think of reasons why we have to do it, because Irish patients are suffering. I'm talking about health now here. Irish patients are suffering in terms of they're not getting the appropriate, say, novel therapeutics, novel diagnostics that, say, their counterparts in England are getting, or in France or whatever. And coming back to, and I understand exactly what you've been saying, but we should have some sort of a mechanism, call it what you will, a pseudo department of linked up thinking between education, between health, between industry, all of that, bring that together fast so we can really advance this area.
So make it a cross-cutting.
Absolutely.
Yeah.
Right?
I think you're right. I think there's a kind of a squeamishness in the Irish system, about kind of getting involved, particularly when it comes to health and, private industry and so on. But I mean, there are areas, and I'm sure it's maybe what you're referring to as well, Owen. We've got a new genomics, national genomic medicine strategy now, and there's absolutely no way that's going to be delivered at all without involvement and partnership with the private sector. It's going to huge amount of resource and investment all the way. So you're right. We do have to get over that. I think that, and it's not. Of course, I was going to say it's not rocket science, but I mean, other countries do this all the time, so I think we just need to get over ourselves, really.
Yeah. Good point. So it's kind of a cultural change, perhaps a systems change to enable these things to happen more. And that was an interesting question, I thought. What's the value that research can bring to industry? I mean, do we as a research community need to be more articulate about that? About kind of putting it out there, Maria?
Well, I might just maybe more on the previous question, but just it was something that struck me when you were speaking, Teresa, about do we research how to research? And so with my a different hat on, I was part of an Enterprise Ireland funded research centre, industry-led research centre in UCD called ARCH, Applied Research for Connected Health, and we were funded for 5 years for quite a lot of millions. I can't remember exactly how many. And there's a paper that two of my colleagues wrote afterwards. Susie Geiger, you can look it up there, anyone who's interested, about that process, because we came out of it probably individually, got a lot out of it, but did the health service get a lot out of it? My own thing would maybe probably not. And Susie and another colleague of ours, Nicole Gross, go into the dynamics of that, because unless you call out all of the agendas, and that it's okay to have agendas, like some people just want to make money, or whatever, like you just, if you want to work with people, we have to be understanding that there's multiple agendas, rather than pretending maybe that we're all here for some altruism or whatever. And I suppose going into bed with people with your eyes open, I suppose. And it's an autoethnography that they write, so it's a very easy read. So I think understanding the payback of what we've already done is important before maybe launching into different strategies. Would be my own.
Yeah, making more of what we've done, Chris.
Yeah, I think there are instances where there are public-private collaborations going on, particularly maybe in the enterprise space and SFI. And I know in kind of talking to officials in, say, the Department of Enterprise, they come to me and ask, or say that the health system is actually very hard for companies to penetrate and cooperate with. And I think that's maybe a cultural thing and maybe a historical thing, but I think it's probably something that we need to move towards, embracing the possibilities of having kind of industry and researchers and government working and clinicians working together to kind of help solve these problems.
Are people put off by the regulatory frameworks that come in on top of them, which that may not in other spheres as well?
I think, the regulation is an issue. I think in many ways we have to get our own house in order to make it attractive and easy for companies to engage. So we have to help create a HSE where research is an embedded kind of function within the organisation, and it's an organisation that's really led by research and research evidence, and that the people who are in that organisation feel empowered to conduct research, and that's supported.
Absolutely. Janice, did you want to come in here?
Yeah, I'm just keeping on that theme. Actually, we have invested in a small industry engagement team within the HSE, and I think that it's taken them a little bit of time to build up their knowledge and those internal relationships of trust. But what we are now working towards is a pathway that industry can come along and engage, because they often arrive with their ideas and then they bounce off different parts of the system and go away, disgruntled. But we want to try and make a pathway so that when they come with an idea or something that they want to look at, that we know where to send them, and they will get an answer
so
and a response.
Through that kind of maybe
and I think
slightly
that's
Byzantine structure.
I think
absolutely.
that's part of making it an easier place for them to work with.
Yeah, and it's funny, talking about making things easier. And I mean, we're all human. We all have a limited amount of energy to put into things. So if a path is easier, we'll take it. One of the challenges that came up in one of the tables was things like legal agreements, data management agreements, those kind of contracts, a lack of standardisation sometimes in research, so that people are spending a lot of time dealing with that paperwork. Again, what can we do? Even things like getting ethics approval, if you need to get local ethics approval, which a lot of projects do. There may be huge time kind of lags on those and everything. So what can we do to make it easier for the researchers in the first place who want to be sort of setting up these more complex things? Owen, yeah?
Yeah, so if I could just use the example of paediatrics and adolescent medicine here. As you know, we spoke about academic health systems earlier on, and this is the way forward. This is the interface, getting better outcomes for our patients. So within Children's Health Ireland, then, we had the unbelievable task to try and pull 4 academic partners together into a memorandum of agreement, which had never been done before on the island. So most hospital groups, just for everybody to know, there's a hospital group is associated with 1 university partner. CHI has 4 university partners. You can imagine the complexity of that. So I started off as the chief academic officer with CHI with auburn hair about 4 years ago. And after numerous sort of months of meetings between the academic partners, we eventually got to this legally binding agreement between the 4 Dublin-centric universities, TCD, UCD, RCSI and DCU, with CHI. So we're building this paediatric academic health science program at the moment. We've just appointed a new CAO, a Director of Research and Innovation as well. That's how we get around all of the stuff you've been talking about, those barriers. We bring it into one structure, and it should be the same for the other hospital groups. Or they're not going to be hospital groups now, they're going to be torn down, as we know. They're going to be regional health authorities in keeping with Sláinte Care, community and GP. That's how we do it, through a model structure.
So we build a functional overarching system, and things are standardised within that system.
That's the way we're doing it in paediatric.
And just if I could come in, because I suppose that's the raison d'etre of HSE research and development, and Anna Therese, who's leading on that, and I work with Anna. And I suppose that's what we've been, tasked with doing, is, reforming the research ethics. There's it's interesting because, in similar vein, I feel like I've been holding a counselling session with anyone I've spoken to today once they realise that I work in anything to do with ethics in the HSE, and I have been that person on the other side where a hospital has asked for 16 copies, hard copies of an ethics form, etc., and I suppose something that I've been thinking of today, and I was saying to Karen earlier, I really felt seen and heard by her, talk about the pipework, because, as someone who's coming from being very research active, and there's a lot of non-sexy work in research generally, but there's a lot of also very creative and innovative, and you get to do your research. The pipework is sustained overalls work is what I'm finding, and so it's not sexy, and nobody really wants to talk about it except when there's conflict, and I suppose that's what we're seeing at the moment. And I don't know so I suppose what the HSC Research and Development are trying to do is reform the ethics, and the reason for that reform is because of the lack of standardization, the ad hoc nature, the lack of governance generally, and because of that, the lack of potential safety in that system. And I suppose I've spoken to people today about, but don't stop business as usual while you're trying to do the reform. And, and that sounds great. And the analogy that has been in my mind is like getting a house renovated. And it's like, do I sit there in the, pardon my French, in this shit, while everything is redone and it's like not pleasant? Or do I move out? Or is there a way that I can go from workaround to fabulous new system? And I suppose it's reminding me of the work that we did in Arch around electronic health records, which, obviously are still TBC, and so it's like you have to have slack in the system to change. And when it comes to funding, like in fairness to the Department of Health and the public generally, I think when they think about health service funding, research is not number one on anybody's agenda when you've got people waiting on trolleys and not being seen, real unsafety in our healthcare system potentially. So unsafety in research is probably, it's hard to get the funding that we need to do it.
Though, Maria. It's
all completely.
That lack
You're
of
preaching to the choir here, but
that lack of safety is an outcrop of a system that needs to be overhauled from every direction.
So we're trying, and that's, I suppose, the short answer, and
But those roles, I mean, that work has to be resourced, because I was struck at it. I think maybe I can't remember if it was Karen or somebody yesterday, I think, used the term hinge actors. This idea that there are people whose job it is to actually do that. So you think of something very practical about standardising. That needs to be somebody's job to do that and to deliver on that and to just get it done. We're not sending somebody to Mars here. It feels like it sometimes, but so I think perhaps we actually just don't resource these things sometimes. And you're absolutely right. People don't think, when they think about health, they think about trolleys and all the rest of it. But in a way, what we spend our time and our money on is also a reflection of our true priorities. Yeah. So if we're not spending our time and our money on these things, then clearly it's not yet a priority or enough of a priority for people who actually make these decisions. So if it really is a priority, we need to resource it.
Yeah, and we need to articulate it as well to the people with the means to resource it. It's interesting, Owen, you mentioned there about that need for kind of the cross-cutting. There was a suggestion from one of the tables of creating an entity to facilitate research more generally in Ireland. Kind of every aspect of health research, everything from the HRB, the research performing organisations, the health system, a bit like sort of the NIH is kind of overarching. So maybe that. That's where all this could be done. Maybe just we need that other level. People also spoke about it might be nice to have broad networks for people with those roles that enable research. So again, the people who I just wanted to make that comment. Skills and competencies came up. So things like the need to encourage the skills to collaborate among people when they're training, kind of, in their initial training, master's, PhD level, how do they do that? We do see great examples of that in things like the TMRN, the Sphere programs and everything. How do we get more of that, Deirdre? And this is something that, we do see in some aspects, for instance, the Centres for Doctoral Training and CRTs and everything. So what can we learn from that to kind of, encourage more of it in the health sphere?
Sure. I suppose I'm new enough in this role, and my previous experience was 25 years in the university setting, in a sort of head of school role where skills, education, research converged into one individual a lot of the time. You know, people were researchers, they taught in classrooms, you know, they work with students, you know, so it's almost, you know, at top level it broadens out and then converges right down into individuals that will do all of this stuff. You know, so there's real challenges there. In my head, I don't think you can ever separate research, innovation, sort of implementation from the skills you need then to kind of scale that implementation across. I'm sorry, I'm a computer scientist by background, so I'm sure my terminology isn't resonating, but you know, it was part of the rationale for the establishment of the DFERS government department, which is further education, higher education, research, innovation and science together in one government department for the first time. One of the major policy developments over the next couple of years will be the development of a unified tertiary system, which is looking at those interlinkages. And I think DFERS itself has a role then to bridge that skills education with the research agenda, you know, and maybe as that sort of neutral, honest broker with spokes into the various, like the health domain, agriculture domain, enterprise, etc. You know. So, but absolutely, in my head, I don't think you can ever separate those two things.
Great, thank you. Chris, did you want to say something?
Well, just I suppose we're working with DFERS to kind of increase the numbers and skills that are coming into the health system. So it's about us kind of communicating what skills are necessary within the health system, and then how are they looking at the throughput and how are they coming through from the universities. And I think within that, if there's particular training that's required within you know, cross collaboration or innovation, then you know, that's something else that we could add onto the agenda.
Great, and starting it as early as possible. I think it's no more than communication. I think you need to be day one. You need to be setting these things in stone. I'm conscious that we are kind of getting to the last 10 minutes or so of the discussion. So if anybody does have questions, you know, if anything arose on your table that you feel we haven't talked about here, or if you have any questions for our panel for anything that arose in the last 24 hours. Mary, you've got your hand up over there. If you just wait for the microphone, I think Rachel's going to run over with it. And is there anybody else got a question? We can get you a microphone afterwards. Yeah, hi. How are you doing?
Thank you. Somebody else going ahead?
Yeah, Mary, off you go. Yeah.
Okay. Thank you, Mary McCann from Trinity. And in relation to the ethics, I mean, I'm running a longitudinal study in people with disabilities for the last 15 years, and thanks to the Health Research Board and the Department of Health. Every wave, I have 138 ethics committees to go through. There is about 15 people on each ethics committee in each organisation. To me, what a waste of public money. So really, something has to be done about this, and I think with a huge degree of urgency. Thank you.
Thank you. Those are scary numbers. I'm just going to take a couple of questions and we'll give them to the panel. So, yeah. I can't hear you. Oh.
Hello?
Oh,
Is it working?
Might need to use the other one. Thanks.
Thanks, that's great. Hi, my name's Steve Thomas from Trinity College. I'm just a little bit worried about the love-in for the private sector here. So I'm going to push back against that, because I think you've got not a very good track record of involvement of the private sector in health. You've got very high prices for pharmaceuticals historically. You've got a private health insurance industry that hasn't really added to the system. It just robs Peter to pay Paul for in terms of access. You've got medical devices being pushed through very pro-private market legislation and not being regulated. You've got a problem of lack of entitlement and of universal care, meaning that some people just don't get the chance because they haven't got the ability to get through. So I think there are lots of different private sector interests which are helpful, obviously, but there are many more which are pro-private, pro-market, pro-profit, and who aren't going to help you or going to come with a very strong agenda. And I think we have to be very careful how we address this. And I wouldn't want us to be having to respond to an EU pro-market agenda when we're thinking about our own research.
Okay.
Thank you.
Thanks for that. Okay, so maybe the panel can anybody on the panel want to talk about ethics or the sort of the need to be very, very careful with the pro-private agenda?
But just to say, the ethics, I hear you completely, and I suppose that's what we're trying to do, is to get away from, the idea is that each of the RHAs, the regional hospital or
health areas,
don't lose faith in me because I don't know what an RHA is. Is to have one in each, and that you can get multi-site approval, and that all of these things will hopefully be streamlined. And I think what strikes me is also that we've no end of good ideas and good solutions, and the issue really is, from my perspective at least, is the implementation science piece. It's, are we willing to do the hard work to actually change? Are we willing to make it a priority? Are we willing to, and I think, going to industry is often a deflection from not wanting to do the work ourselves. Maybe someone else will do it for us on the side or something. But this is doable. So it's a bit like Karen was saying earlier. It's simple, but it's not easy because there's emotion involved. And I think we're trying to bring in some of that research about how you implement these things. So for example, there's lots of great research on trying to implement electronic health records. And the barriers to that, and professional boundaries comes up time and again as a number one, maybe not the number one, but a significant barrier. And we have to be okay with talking about that. That ethics committees are used to having power. So what does that mean when there's 6 rather than, I don't know, I'm hoping that the 138 are not all HSE research ethics, but maybe they are.
No, they're not, but every region has its own ethics.
Yes.
It's still an astronomical number for you to have to deal with. That's the bottom line.
Yeah.
Did you want to come in here on that, Janice?
Very briefly, just to say that change is always painful for people, and I know that we've been through a lot of this already. So there's always something out there that you can build on rather than having to reinvent the wheel. And around that whole issue about contracts and costing, there are people going down those tracks that would be more than willing to help to support people through that process. But yeah, having just come through a big process of change at the moment around our own governance system, you start off with all the animosity and all of that sort of caution and wariness, but actually we're actually on the other side of that now, where everybody's going, would you get on with it? Just get it done and let's get stuck in.
Good to
so
hear that.
you do get, it's that whole theory of change, and you can see that happening now. So it is hard work, but eventually I think worth it.
Good stuff. And I know, sorry, Chris, did you want to come in there?
I feel like I should say something on ethics approval. I think the 6 RHAs having an embedded research office and a research ethics committee should be very useful in terms of getting kind of expedited research ethics approval. I think coming as an outsider to the health system, I find it strange that there isn't more mutual recognition of ethics approvals in place. I'm not quite sure why all those approvals are necessary if Trinity couldn't recognise an ethics approval from UCD or UCD from UCC. But anyway, I think the RHAs provide a model maybe where we can have ethics approval at a regional level, and then at the national level, a huge amount of time with Alistair and the national office in the HRB, kind of working on trying to establish a national research ethics approval system, which is linked to the EU directives in clinical trials and medical devices, which hopefully, there's still a lot of teething issues, and the people who are on those committees have put in a huge amount of work. And I don't think we have a sustainable system yet, but I think we have to kind of figure it out quickly. But I think in the future that will offer a model for kind of national level research ethics approval, which could also
hear. It's literally
expedite
in
things.
pipes. Good stuff. And then to Steve Thomas's question then about, we heard the eye-watering 138 ethics committee. If any of you were at the national conference, the HRB national conference in November, Michael Barry was talking about eye-watering costs of high-tech drugs and things like that. So how as researchers, do we sort of go into this with our eyes open in terms of, working with private companies? As Maria said, there's agendas there, and how do we make sure everybody's protected, and ultimately the patients are protected at the end of it? Owen, do you have any thoughts on that?
Yeah, again, I would totally agree. We need to be smart about this, and we need to get proper advice about this. It has not worked in some countries, whereas other countries it has worked. We should look at where it has worked and get advice around this as well. Reach out. This is the whole area of collaboration in terms of changing the dynamic. Cost of pharmaceuticals. I was the National Haemophilia Director back in 1997, and we were the first country in the world, on the back of HIV and hepatitis C, to introduce recombinant products. The first country in the world. Yet within a year of that, the cost of a factor 8 molecule was 2 times more expensive than it was in Belgium. So we need to get smart about this stuff, And I was part of the Genomics and Genetics Strategy Group as well, and from our dealings with the international sort of consortia that we were dealing with as well, I mean, it's in the strategy. We will not be able, in the near future, to deliver precision medicine in this country if we don't get into partnership with, industry, pharma, and all of that, with the academia and the healthcare programs. We've got to be smart about it. But you're right, there are some things there that need to be sorted.
Yeah, absolutely. Sorry, Maria, did you want to
Sorry, no, I was just going to say, in a way, Steve articulated very well what I meant when I said squeamishness about all of this, because I think probably a lot of people would share concerns about inequity of access and all of those things. But it's just, as Owen says, it's just a fact that there are areas of research that we simply cannot progress just by the public system alone. It just can't happen. So, I mean, you have to be absolutely clear and upfront about what people's agendas are. There's nothing wrong with a private company wanting to make money. I mean, that's what they do, but you have to be absolutely clear about that and understand how that aligns.
How that potentially impacts patients down the line.
Yes,
yeah, exactly.
Absolutely.
Yeah, absolutely. We have time for one more question. You had your hand up for a while, so off you go.
No problem. Thanks a million. Great to see the panel up there. I suppose, because we're talking about health rather than just research, the biggest partners out there right now are the HSE, VHI, the private hospitals, and we should be partnering with them for starters. That the whole system is built on incredible mind-numbing inefficiency. It's incredibly backward, it's very poorly structured, and it's very sad. We're drowning in data, and a lot of it's readily available and could solve a lot of problems overnight. I spend about 6 to 7 hours a week just logging into the various systems in our hospital in Galway. Now, if the HSE want to pay me a professor's salary just to spend half or a full day a week just logging in and out, never mind when you get in to do something, that can't be value for money from a taxpayer perspective. So despite all the concerns, I think the sooner we kind of get with it and have a culture change from no you can't to Obama, yes we can, the better. When I was in Boston almost 30 years ago now, Irish engineers set up the system where if you had an X-ray in Hawaii, I could see us 2 seconds later in Boston. That system was built by UL graduates, Trinity graduates, UCD graduates for the American radiologists. That system is still in existence. Yet when I log into Galway in my clinic, I can't see the X-rays that were done about 200 yards up the street for my patients who spent €350 in a taxi coming down from Belmullet that they borrowed from their friend for the one appointment they waited for 4 years. I just think that's shocking. And I don't care what the EU say, but if it wasn't for Belmullet, the EU wouldn't exist because we'd all be speaking German. So I think it's about time we adapt to this yes we can attitude. Over 70% of the research in America is funded by private industry. We go in with our eyes wide open. We need to put proper structures in place, as Owen said. We need to be smart about it. But if we're smart and we're accurate and we're efficient, we'll have a far better healthcare system. Every country in the world, or every system in the world that's brought an electronic record show they save about 30% of the healthcare costs and they provide better outcomes for their patients. I was in the National ICT Strategy Group for 3 years. I was speaking at meetings in Dublin. We got 17 billion in funding. We got the system we used in the VA in the 1990s. I was coming up from my holidays. I got disinvited the night before. The GP representative got disinvited the night before, and the government said no. So 7 billion for Sláinte care isn't going to fix diddly. We don't need trolleys in A&E. If we had a little bit of innovation in the HSE, and we talked about smart modern medicine rather than something that happened to Granny back in 1981, we wouldn't have any trolleys in A&E. We don't need more beds. We need a much better system that's built on accuracy, efficiency. Michael Barry talks about the costs of the drugs. We were the first in the world to switch everybody to biosimilars. everywhere around the world thought that was amazing. I was asked to speak all over the place because this is amazing, it's very complicated. I said, it couldn't be simpler, it's half the price. People went, that's amazing. I said, you're supposed to be a professor, like cop on, it's 50% less. It couldn't be simpler. Yes, in Ireland, we took a tanking, they took the staff off us and they closed down the unit. You know, we need to be smart about embracing innovation. If it's good for the patient, it's good for the doctor. But we really have to focus on being accurate, efficient, and having a yes, we can culture if we're going to change things.
And if I could just speak to that, I suppose when you say that, I don't think that, well, maybe there's people who disagree with you, but I would be like absolutely hard yes to everything you're saying. And I suppose that what comes up for me all the time is like, why? We're a small country, we're a rich country relatively. Like, we've got lots of innovation, lots of innovative minds, lots of good education. So what's the blind spot? And I suppose, as someone with my own background in sociology of organisations, I suppose my lens immediately goes to culture and to what's going on that we can't do this well. I don't know the answer to that, but it's, you know. Yeah, the pipes.
Gunk in the pipes, exactly, gunk in the pipes. Well, listen, everybody, we've just gone past 12. I'm conscious there's lunch and trains and everything to be considered. So I'm just going to wrap it up. But I just want you all to say a huge thank you to our panel for coming up here and sharing their insights today. And thank you for the questions as well. So thanks, everyone.